Thank you so much, Katharina. Again, a great presentation of a young female researcher. Okay, great. So we open up the panel for the discussion. Welcome all of you. And I have a look at the chat. So I start with a question from Sharon. That was the first question coming in from Makela. Is the difference in type 1 versus type 2 MI still differ by gender, or does it still differ by gender if you adjust for intravenous drug use? Makela.
Thank you. That's an excellent question. In the manuscript by Dr. Crane et al. That was based out of the US CNIX cohort and published in JAMA Cardiology in 2017, the authors looked at the question of among women with HIV who had an MI, what percent of those women had a type 1 MI versus type 2 MI, and then among men with HIV who had an MI, what percent of those men had a type 1 MI versus a type 2 MI. The authors did not compare sex differences in the risk of each subtype of MI controlling for relevant risk factors, which would include IV drug use. We do, though, plan to ask and answer this question in the context of the REPRIEVE trial, the randomized trial to prevent vascular events in HIV, which this group may know has already recruited 7,770 participants globally. So this will be a good opportunity to ask and answer this question. Thank you.
Thank you, Makela. That was a clear answer to this question. Now, Teresa, you want to take the next question?
Sure. And yeah, checking at the chat, the next question is from Peter Hunt for Dr. Swan. And the question is, very nice presentation. It's not a question, of course. Commendation, very great. So the question is, was the analysis of age at menopause adjusted to differences in confounding factors that might affect the age of menopause, like substance use, BMI, etc.? And do you have a theory as to why women with HIV are more likely to self-report earlier menopause compared to FSH, defined age at menopause?
Thank you for this question, and I should clarify I'm not a doctor. I'm a mere grad student, but thank you for the promotion. So we haven't yet done adjusted analysis for a full data set. I have done some preliminary look at this, and it doesn't seem like if we adjust for BMI or for substance use or ethnicity, hepatitis C, there doesn't seem to be any difference. Still, it doesn't affect our results. The only factor that does seem to make a difference in age at menopause, at least in this first look at the data, is smoking, which is often already seen in the literature that women who smoke tend to have an earlier age at menopause. But yeah, it'll certainly be interesting to finish that analysis. For the second question about why women living with HIV are more likely to report earlier menopause, I think it probably is just because of that higher prevalence of hypothalamic amenorrhea. And if you recall in the scatter plot, you can see that there were some women who were reporting menopause around the age of 30 to 35. So I think it's likely that that was the experience of hypothalamic amenorrhea rather than menopause, but it being misinterpreted by either them, their physician, the person doing the analysis. Thank you.
Thank you. And Annette, just to mention, good you said you're not a doctor, because I wanted to ask you that myself and say, that's how I feel. I keep telling my doctor that I'm experiencing menopause, and she says, no, you're not. And so thank you for explaining that very clear. Annette, go ahead.
Yeah, the next question is from Makela to Shada, and I would suggest, Makela, you can ask her directly.
Great. First of all, that was a wonderful presentation. So great job on that. I had a question. So it starts with a statement and then it turns into a question. So as you highlighted, opioid use has been described to decrease GnRH secretion and in turn FSH. And this is potentially a contributor to amenorrhea, such that women who are not in menopause may appear to be in menopause by history of amenorrhea alone. But I was wondering whether it could also be the case that women who are actually in menopause and who use opiates may experience opiate mediated suppression of FSH and thus be misclassified as premenopausal by methods which rely on FSH levels?
Yeah, I think that's such a fantastic question, and goes to why it's so important to adjust for like history of opiate use or current opiate use. So I think that will be a really important thing for us to consider when we do a multivariate regression. I also think it would be fantastic if we could look at anti-Mullerian hormone levels, which would likely not be impacted by this. So if we can do that in the future, I think that would be a really ideal way to really make that distinction and not have that confounding by opiate use. Thank you so much for the question.
Okay, maybe if we don't have any other questions in the chat right now, maybe Shada, I ask you a question. So you said FSH plays an important role for research. I'm a simple clinician now. I see many women, aging women. Does it make sense to determine FSH in these aging women, or when should I think about it? Just give me some practical advice.
Sure. Yeah. So I think current clinical guidelines are not to test FSH levels to determine if someone is in menopause. I think that's because in general, the definition is not having a period for a year, and not because of other factors. However, I think it might be useful for those women who are at less than age 45 and have risk factors for amenorrhea. I think that's when it might be good to look at their FSH, but also maybe their TSH and their prolactin, and just see if there might be another reason why their periods have stopped early rather than it being menopause. But I think for women who are older, it's usually safe to assume that they are indeed in menopause.
Yeah, thank you so much, because my aging women, my older women always ask me to look for after the hormonal levels, and I say, well, I can determine them, but they don't tell me a thing. So it's just a clinical decision, this are you menopausal or not. But for premature or early menopause, it could make sense on the individual basis. Okay, thank you so much. So Teresa.
Sure.
Any other questions?
Not yet. Please continue to post your questions on the chat. I had a question for Kathleen. One of the things that we clearly know is that young women who are repeat mothers are experiencing various things. As women living with HIV, we don't live a single life issues. And so we see all this intersectionality of issues or challenges happening. And I was wondering whether you had an opportunity to see if all these things combined really can lead to mental health issues or challenges for women with more than one child. I'm not sure that Katrina is on. Or anybody in here can respond. Great, Annette, maybe you can go ahead as we wait for Katrina to rejoin us.
Yeah, we lost her somehow. Hope she will be back soon. I don't see any other questions. It's unbelievable. The audience is not taking the chance to put the questions in the chat. Well, I would have another question again as a clinician to the first two presenters. So do I need to check, or do I need a cardiologist earlier than I used to do for my aging women? So does it have any clinical implications, your research, on the higher rate, for example, of MI in the women, more risk factors? You see differences, sex and gender differences here. What would you recommend? So this is to Makela and Mabel.
Mabel, do you want to take that one?
Yeah, sure. I'll try to take a stab at it. So thank you for that question, Annette. I mean, I think that honestly, as it pertains to some of our research data, we're still trying to understand the clinical implications. I think that by and large, at least the data that we have, is that there are some factors that we're seeing that early on women with HIV have that have been shown, at least in general population studies, to be predictive of either development of heart attacks or heart failure. And so we don't necessarily have an integration of those research findings into clinical guidelines, but I do think, just as with any other kind of patient population, when there's this kind of general consensus of data suggesting potential heightened risk, that having that in the back of our minds of potentially having our patient living with HIV seeing a cardiologist, sooner rather than later is a great idea, especially if you have any specific concerns of other, other underlying risk factors for heart disease.
Yeah, I would keep
Markella, I
that
don't know
in
if you want to add
mind.
anything,
Yeah,
but.
we have more and more aging women and peri and postmenopausal women, so they are at risk, and we should keep that in mind and check earlier if there is something wrong or if they need medication. And yeah, I think that's an important point. So
I think that was a great answer as well. And I would just add that talking to our patients about being open in sharing any symptoms they may be having, because sometimes people may downplay their symptoms, but we would want to know, even if they're atypical, they may be relevant. And secondly, doing everything we can to modify those risk factors which are modifiable. So cigarette smoking, IV drug use, excess weight, and different risk factors that may contribute. Everything we can do to address the risk factors will help preserve cardiovascular health over time in this patient population.
yeah, I just want to mention that the differences, the sex and gender differences in this cardiovascular diseases are the origin of gender medicine. So that was first time we saw there are really important differences, because you mentioned the symptoms, and they can really differ between men and women. Okay, Teresa, I think we got another question from Peter Hunt. Would you take it?
Sure, and for you, Mabel. Thank you. And can you speculate a bit more on what you think the mechanistic basis might be between monocyte activation and decreased cardiac strain?
Thank you for that question, Dr. Hunt. So this would be honestly purely speculation, since we don't necessarily have an answer to that. But as I was trying to explain in the presentation, cardiac strain is really measured from the deformation and the changes of the heart muscle tissue. And so we can postulate that potentially this higher amount of inflammatory monocyte activation may have contributors to, for example, the amount of scarring or fibrosis within the heart muscle tissue. That may in turn lead to changes of how the heart muscle tissue is deformed when it contracts. That's just speculation. We still definitely need additional studies to look at that, but that's one of the things that I thought about when we saw this finding. And I guess Markella, if you wanted to add, since you're also on this study as well.
Yeah, no, I think that's exactly right as the leading hypothesis.
Thank you.
And there is a thank you. There is, sorry, I was concentrated on the chat already again. So there's a question from Sharon for Lorette. Do you know how many of the women continued, whoops, sorry, how many of the women, I'm back again. Did you miss me? Okay, so a question from Sharon again for Lorette. Do you know how many of the women continue to have diabetes post-pregnancy, postpartum? So sorry for that, I got lost.
No problem. Thank you very much for the question, Sharon. So unfortunately, the type of data that we collect is it's very specific. So it's only in pregnancy. We don't collect post-pregnancy data, but there is definitely a body of evidence to suggest that women who do have gestational diabetes in pregnancy are more likely to develop type 2 diabetes later on in life. Perhaps future work to springboard off of the back of this study would be to link to other administrative data sources to find out about longitudinally follow up these women and see post-pregnancy for women who have gestational diabetes, whether they do later on develop diabetes.
Okay, thank you, Teresa. Anything else in the chat?
No more questions. Annette.
Well, I could just add for Lorette, I was really surprised that there was no relation between gestational diabetes and the regime the women were on. So the PIs are out, INCIs are safe. So that somehow is good news for us as clinicians. Again, just other risk factors we have to keep in mind. So that was important work also. There is a question from Ricardo Massman from Makela. Thank you for the presentation. I'm doing my PhD on HIV and cardiovascular risk. That's good. In my experience, it is very difficult to isolate individual factors to determine if there is an increased risk in people living with HIV. We also have few major events of cardiovascular events, infarction, stroke, which makes me question whether the major factor ultimately is not age and smoking as in patients without HIV. What is your experience in those patients who presented major cardiovascular events like infarction or stroke? That was a long question. So what is your answer?
Thank you for this question. There have been a number of large-scale epidemiologic studies over the years that have shown an increased rate of myocardial infarction among people with HIV, which persists even after controlling for relevant risk factors such as age and cigarette smoking. And most recently, there was a presentation at this year's 2022 CROI conference by Dr. Triant and Dr. Silverberg that showed that these trends persist. But once again, I do think we'll be gathering really important information from the ongoing REPRIEVE trial. And just a word about that for people who may not know, REPRIEVE is an international trial, prospective, that is randomizing people with HIV who have low to moderate traditional cardiovascular disease risk to either pitavastatin calcium, which is a statin medication, or to placebo, and then is following for many years, on average 6 years, for major adverse cardiovascular events such as myocardial infarction and stroke. And these events are being formally adjudicated. So this study will provide some critical information on the factors which may predispose to major adverse cardiovascular events among people with HIV, and also whether statin therapy may be beneficial. So more to come.
Thank you so much. So Theresia, if there are no more questions coming in, I would say it's time to close this session. What do you think?
Yes, I think so. Thank you so much, everyone, for your perfect presentation.
Yeah. So I'd also like to thank everyone. And now we have a 15-minute break, but be back on time because session 7 will be on hot topics in HIV and women. So don't miss that. Stay with us. Take care. Bye.
Bye.